You are listening to the Nurse Documentation Podcast, brought to you by Nightingale.
Nurse documentation. Protect the care you gave. Protect the license you hold. With every note you save. Nightingale, where good care is safe.
Okay, let's unpack this. Imagine you're a nurse leader, a CNO, a director of nursing, maybe running a unit, and you get that email.
The one that makes your stomach just drop.
Exactly. It's that unexpected audit request or maybe, a notification that some small patient complaint from months ago just escalated.
And it's now a formal inquiry. And they want all the documentation.
Right. And suddenly you have this realization that the quietest, most mundane part of your unit, the daily charting.
The thing everyone sees as a chore.
That's the one. It's actually the biggest time bomb you were sitting on.
It's the invisible risk leaders inherit. I mean, we spend so much energy on clinical competencies, on safety checks, on staffing.
All the visible stuff.
All the visible stuff. But the one piece that determines your facility's legal vulnerability and really the professional protection of every single one of your nurses. It all comes down to the quality of their charting.
To the pixels on the screen. And that's what risk leaders aren't really trained for, are they? We're great at budgets, at staffing, but nobody really teaches you how to spot and neutralize the legal ammunition that your team might be accidentally writing into their own charts.
And that's our whole mission for this deep dive. We're looking at a guide that was designed specifically for this, to give CNOs and Dons the actual tools, the exact phrases, to eliminate that ammunition.
So the real shift in perspective.
It has to be. You have to frame documentation risk as a leadership responsibility. It's not just a problem for the bedside nurse to figure out.
Because when that chart ends up in a courtroom, sometimes years later,
that document is everything. It's the sole defense for the facility, for the nurse's license. The core legal concept is crystal clear. It's not documented. It legally didn't happen. We all know that one.
We've had that drilled into us.
But what we're focused on today is the, frankly, more terrifying truth. If it's documented poorly, even if the care was absolutely perfect, those words can be twisted and used against you. It's basically self-sabotage by documentation.
That distinction is so critical, especially for leaders listening. It's not just about proving you did the clinical work.
No.
It's about making sure the specific words you chose, or that you allowed your team to choose, don't hand the opposing counsel a tool to just undermine all that great care.
Exactly. You're moving documentation from being this administrative task
I have to check.
to being a really sophisticated risk management lever.
Okay, so let's get into the weeds. Let's ground this in what's happening on the floor every day. We know nurses are rushed, they're tired, they're working these incredibly long shifts. They're skilled, experienced professionals. So why do we keep seeing the same mistakes? Why do good nurses default to these vague, unsafe phrases like patient tolerated well or non-compliant or just refused?
It really boils down to habit and haste and, a bit of institutional history. When you're rushing, you're charting on the go, you reach for these cognitive shortcuts.
They feel efficient.
They feel very efficient, tolerated well, checks a box. But in doing so, it strips out all the context, all the objectivity you need for a strong legal defense. Our review of this shows these phrases fall into, three really dangerous buckets. They're vague, they're judgmental, or they're subjective.
And malpractice lawyers are looking for those specifically.
They hunt for them because those words immediately introduce doubt. And that opens the door for some really damaging interpretation later on.
So ambiguity is the real enemy, because that doubt is what costs facilities money and nurses their licenses.
Absolutely.
Let's take the prime example, probably the most common one. Patient tolerated well.
Yeah.
You see it after procedures, meds, everything.
It's a massive red flag. It's a huge one because it's completely subjective and it gives you zero data. It implies an assessment happened,
Right.
but it doesn't give you a single objective measurement from that assessment. So think about how that gets challenged legally. A patient has a bad reaction, later nausea, a pain spike.
Something that leads to a readmission.
Exactly. And that note claiming they tolerated well now suggests the nurse either missed something critical or worse, that they just didn't do a thorough assessment at all. It becomes evidence of a failure to observe.
And as a leader, I'm thinking, I know my staff did the vitals check. I know they checked the pain level. But if all they write is tolerated well, How does that gap between what they did and what they documented play out?
It creates what's called a gap of inference. The lawyer can stand up and say, how can you claim the patient tolerated this well when their blood pressure bottomed out 10 minutes later? Did you check their vitals? If you did, where are they? Because if they're not written down, we have to assume you either didn't do the check or you did it and missed the trend.
So it puts the nurse completely on the defensive.
Completely. Now they have to try and recall a specific event from maybe years ago, when the chart should have been their defense. It should have spoken for itself.
And this is where the guide we're looking at provides such a clear path out of that trap. It gives you the safe alternative.
Yes, and the alternative is structured to be bulletproof. It closes that inference gap. It's all about time, observation, and data. Instead of tolerated well, you write, patient reports no side effects 30 minutes post-administration, vital signs stable, BP 12278, HR65, RR16. No complaints of nausea, dizziness, or allergic reaction.
It's specific.
It's totally specific. It shows the assessment done, the time frame, and the lack of specific symptoms. It shifts the entire note from subjective opinion to objective, measurable fact.
Which leads us right into the danger of what some people call the V words in documentation, these vague subjective terms. What about patient appears comfortable or patient stable? They seem so benign.
They seem caring even, but they're just as dangerous. They rely entirely on the nurse's interpretation of external cues, which are, highly subjective.
How do you define comfortable?
Exactly. A lawyer will shred that definition. If a patient is internally guarding severe pain but they're stoic and the nurse writes appears comfortable, you've just created a huge problem if that patient's condition declines.
And stable.
Stable suggests a cursory glance, not a focused, data-driven assessment. I can just hear a charge nurse saying, look, I know my patient, they're fine. I don't need to write out every single vital sign every single time.
Yeah, I can hear that too.
But the safe alternative for stable is so critical because it forces that specificity. It forces the proof. Don't just write the word stable. Write the metrics that prove stability, especially relative to that patient's own baseline.
So show your work.
Show your work. Vital signs stable relative to baseline. BP 111-76, HR68, RR14, SpO2 97% on room air. Patient alert and oriented ×4. No acute distress observed. See? When those objective facts are there, the word stable becomes a conclusion based on evidence, not just a guess.
What about another really common one? Patient has no complaints.
That one carries a similar risk. It implies a passive assessment that you just waited for the patient to speak up.
Instead of an active one.
Right. A lawyer asks, did your nurse specifically ask about the incision? About shortness of breath? About a headache? And if your note just says no complaints, it suggests you didn't. It suggests a very generic checklist approach.
So the chart needs to show what you actively assessed for.
And what the patient actively denied. The safe alternative is just to list it out. Patient denies pain, nausea, dizziness, shortness of breath, or other concerns at this time. It proves your diligence.
Okay, let's wrap this part up with maybe the most egregious one I see in shift summaries all the time. Patient doing well.
That is almost legally meaningless. It can be contradicted by literally any event that happens in X. It has no context, no assessment, no action. If a nurse writes that and the patient develops sepsis 3 hours later, that note is going to be Exhibit A for the plaintiff's attorney.
So what's the fix? What's the safe alternative?
Okay. It demands observable metrics. You need to show the progression. Patient reports feeling much better this morning. Pain 310, down from 710 with ambulation. Vital signs stable. Tolerating soft diet. Ambulating without assistance. That shows clinical improvement based on data.
So the big takeaway here is that these quick shortcuts, the ones we think are for efficiency, are actually creating these massive interpretive gaps.
Exactly. They turn objective clinical care into subjective guesswork in the eyes of the law.
Okay, so let's pivot from the problem to the solution. Let's connect this to leadership strategy. Leaders are always rolling out these huge, comprehensive documentation education initiatives. 6 months long, 50 policies.
2-hour in-services that nobody remembers a week later.
Right, and they often fail. It's just information overload. We're asking people to overwrite years of these learned shortcuts basically overnight.
And that's exactly why they fail. They're aiming for documentation perfection. But for risk management, what you actually need is a consistent minimum safe standard.
A minimum safe standard. I like that.
The philosophy that really works and what this guide is all about is focused on fast diagnosis and simple standards. You identify a bad habit, the unsafe phrase, and you provide the exact bulletproof script to replace it. It's this focused, repetition-based approach that actually creates behavior change that sticks.
This is where it gets really interesting for managers listening to this. We're not just talking about vague advice like chart better.
No.
We're talking about adopting specific, uniform language across the entire unit. You're replacing a learned vulnerability with a learned strength.
It's about building these micro checkpoints. You can create quick, visible wins that your nurses can see and implement on their very next shift. Think about a manager doing a 10-minute unit risk scan.
What does that look like?
You're not auditing 100 charts. You just identify the 3 most common unsafe phrases your unit used this week. Maybe it's patient refused, WNL, and tolerated well. And for the next 72 hours, you focus only on eliminating those 3. It turns the risk guide into an immediate action plan.
Let's talk about one of the highest impact concepts from the source material. The total failure of within normal limits, or WNL.
Oh, WNL. It's the ultimate documentation shortcut.
And the ultimate risk.
It is the pinnacle of assumed assessment. It's like stable, but for an entire body system. When a nurse charts assessment WNL, a lawyer can just pick it apart. What exactly did you assess? Did you listen to all 5 lung lobes? Did you check pedal pulses? Was skin turgor assessed?
And because the chart doesn't say.
The nurse can't prove their due diligence. The argument becomes, WNL just means I took a quick look and nothing was on fire.
Okay, but here's the tension, right? On a busy floor, a patient is post-op day 7, they're totally stable. Writing out every single parameter feels redundant. It feels time-consuming.
I get that.
Yeah.
But we have to reframe the argument. Stop focusing on the time saved by typing 3 letters and start focusing on the liability saved by typing 2 sentences. The guide shows that you can have clarity and still be fast. You just need to prove the process of the assessment was followed.
So we focus on the specifics. For a respiratory assessment, for instance.
The difference is huge. Instead of assessment WNL, you hit the required objective data points. Respiratory assessment, lungs clear to auscultation bilaterally, respiratory rate 16, SpO2 97% on room air, unlabored, no coughing or use of accessory muscles.
That's the minimum safe standard.
That's it. It proves you conducted a specific, focused assessment. It protects you if that patient develops pneumonia 2 shifts later.
And this applies across the board for a cardiac assessment.
Same principle. Don't just write WNL. Give the snapshot. Cardiac assessment, regular rate and rhythm, HR 72, no murmurs, peripheral pulses 2+ and equal, cap refill less than 2 seconds, no yeah. It takes a moment longer, especially with good EMR templates.
And it shifts the entire culture from passive charting to proof of assessment.
That's the leadership win right there. You're moving from a compliance chore to proactive risk management.
Okay, let's move into the areas that malpractice lawyers seem to target the most aggressively. Medications, patient refusals, and incidents. These are all about action, patient autonomy, and where care can go wrong.
Right. And if the first rule of documentation is, if it wasn't documented, it didn't happen. The second rule, especially here, is, if you didn't document reassessment, you didn't close the loop.
And failure to close the loop is a huge vulnerability.
It is the #1 documentation vulnerability in pain management lawsuits, hands down.
Let's start with those medication shortcuts. Medication given as ordered, or even PRN medication effective.
Those are massive risk points because they don't capture the nursing process. When a nurse charts that, they're failing to document the essential components. The pre-assessment, why did the patient need it? What was their pain level? The patient education, what did you tell them about it? And the most critical part, the post-administration reassessment. Did it actually work?
It suggests the nurse just saw it as a task, not a clinical intervention.
Exactly. An administrative task, and I can play devil's advocate here too. A nurse might say, I gave the med, I saw the patient an hour later, they looked fine. Why do I need to chart a specific reassessment time?
So why do they?
Because failure to document that reassessment implies a failure to advocate. If you give a PRN for pain and don't document a follow-up within that standard 30 to 60-minute window, a patient can legally claim they were still in severe pain and the nurse never came back. That's a failure to meet the standard of care.
The chart has to prove you went back.
The chart has to contain the data to prove you returned and you confirmed it was effective. The safe alternative tells the complete story.
Let's walk through that.
For a PRN, the note has to have this level of detail. Pain reassessed at 1500. Patient reports pain decreased from 810 to 310. States, I feel much better now, resting comfortably in bed, no side effects noted.
So you have the time, the subjective report, the objective change on the scale.
And the patient's immediate status. Without that full story, if a patient later alleges their pain was mismanaged, your chart offers absolutely zero defense.
Okay, now let's shift to those landmines around autonomy and education. Refusals, reassessments, education gaps.
This is where judgmental language can be absolutely catastrophic. We see it most often when a patient isn't following the plan of care. Phrases like patient non-compliant with diet,
Or patient uncooperative.
uncooperative during dressing change. It's so judgmental. It frames the patient as being at fault, and it really suggests the nurse failed to explore why. Why were they resistant? Were there cultural barriers, economic barriers? It's just dismissive.
So the note has to be factual, non-judgmental, and show what the nurse did about it. That's it. You shift the focus back to the nurse's professional responsibility. So instead of non-compliant, you document. Patient reports not following prescribed diabetic diet at home, citing difficulty accessing low-sugar foods. Education provided on diet and glucose monitoring. Dietitian consult placed.
You show you acted as an advocate.
You educated, you escalated, you brought in other resources. It's a completely different picture.
A similar huge vulnerability is just charting patient refused medication. If a patient refuses a necessary medication, your duty as a nurse is to ensure that refusal is informed. They have to understand the consequences. If your note just says refused, your defense is gone. There's no proof of informed refusal.
So you have to document that conversation.
The whole conversation. You have to document why they refused and that you educated them on the risks. The safe alternative looks like this. Patient declines pain medication at this time. States, I want to see if I can manage without it. Education provided on the risk of pain escalation. Patient verbalized understanding and agreed to notify nurse if pain worsens.
It proves you met that advocacy standard. And this same principle, this informed consent to refusal, it extends to all education, right? Especially discharge planning.
Absolutely. Phrases like patient educated or patient understands are just not enough. They're grossly insufficient because they're missing the verification piece.
The teach back.
The teach back imperative.
Yeah.
You have to show how you assessed their understanding. You can't just assume it. You have to prove it. A lawyer will argue educated just means the nurse talked at the patient.
So give us the gold standard note for verifying discharge teaching.
It has to detail what was taught and how it was verified. Discharge instructions reviewed. Patient repeated back instructions accurately, stating, I will take my blood pressure medication twice a day with food and call the doctor if I have a fever. Demonstrated correct technique for sterile dressing change. Understanding verified via teachback. That is defensible.
Okay, last one in this section, and it's a big one. Incident and error documentation. This is where staff can accidentally admit liability.
This requires so much discipline and really clear leadership. You have to train your staff to document objective facts in the patient's chart, not admissions of liability, not speculation.
So unsafe phrases would be like medication error occurred.
Or nurse's error led to a delay in treatment. Those are huge liability traps. They admit fault on the record. The official chart note is for the clinical record only. Blame, cause, analysis. That all belongs in the internal, non-discoverable QA report.
So the chart's job is just to focus on the immediate response to what happened.
Purely. The safe alternative for a med error focuses only on the objective facts. The discovery, the immediate assessment, the vitals, the physician notification, and the patient's status.
So something like,
At 10.30, noted discrepancy. Patient received metoprolol 50 milligrams instead of prescribed 25 milligrams. Patient assessed immediately, vital signs stable, asymptomatic. Dr. Jones notified at 10.35, new orders received, patient remains asymptomatic, incident report filed internally. Notice, it's all about the response and the patient's status. There's no mention of cause or fault.
and what about the unwitnessed fall? The fell trap.
Just charting patient fell is awful. It implies you saw it happen and creates a huge timeline gap. The safe note has to detail the finding, the patient's direct statement, always quote the patient, and the immediate post-fall assessment.
So it's about reconstruction.
It's all reconstruction. Patient found on floor at 14.30. Patient reports, I was trying to get to the bathroom. No visible injuries. Neuroassessment completed. Physician notified. Fall risk reassessed. Incident report completed. You reconstruct the timeline, prove your prompt response, and document a thorough assessment.
So this all brings us to the leadership challenge. How do you, as a CNO or a manager, drive this kind of behavior change, replacing these deeply ingrained unsafe habits, without creating a culture of fear?
That's the tightrope, isn't it?
It is. Because if chart reviews are only punitive, nurses will just stop documenting truthfully. And that's even worse for safety and for legal exposure.
It's so much worse. Leaders create fear when they only focus on the negative. The goal has to be clarity, not more rules. If you find a vague note, the response shouldn't be, you did this wrong. It should be, here's the exact script we use instead. Let's practice phrasing that. You have to shift from audit and punishment to coaching and scripting.
That idea of micro lessons and ready-made scripts seems really powerful. The guide isn't a rule book, it's a playbook for real-time correction.
That's it. And it respects the nurse's expertise. They don't need more education on how to be a nurse. They need specific clarity on the handful of high-risk phrases that are jeopardizing their license. You're just helping them replace an old, risky habit with a new, defensible one.
Like addressing that doubtful language we sometimes see.
Patient claims.
Or, patient supposedly took medication at home. When you use words like claims or supposedly, you are putting speculation into a permanent legal document and you're undermining the patient's credibility.
And it sounds dismissive.
It is dismissive of their experience. The safe way is to just eliminate the speculation, report the patient's statement as a fact, and then document your action. Patient reports taking morning medications at home. Unable to verify. Medication reconciliation completed with patient and family. Provider notified.
Yeah.
You report the statement and you document how you establish safety.
I want to spend a good amount of time on this next point because it's so critical. The difference between describing behavior and diagnosing.
The sources highlight phrases like patient confused, patient agitated, or patient depressed as huge leadership failure points.
This is fundamental. It's about scope of practice. Nurses don't diagnose clinical depression or a medical cause for confusion. That's the provider scope. When a nurse charts a diagnosis, it's vague, it's subjective, and it creates a documented expectation for a treatment that might not be in our scope to even order.
So we have to describe the observable behaviors.
Strictly. This is a primary coaching point for every nurse manager. Instead of the label patient confused, you have to answer how they are confused.
What does that sound like?
It's a structured neuroassessment plus the behavior. Patient-oriented to person and place, but not to time. Repeatedly asking, what day is it? Baseline per family is usually sharp. Physician notified for evaluation of acute change in mental status. It's objective, it's comprehensive, and it shows you escalated.
And for emotional states like agitation.
Same thing. Document the outward signs, not the diagnosis. Instead of just agitated, you write, patient pulling at IV line and attempting to get out of bed, yelling, let me out of here. Reoriented to safety, bed alarm activated, physician notified for possible medication order or sitter.
And for something like depression.
You avoid the diagnosis. You chart the behaviors. Patient reports feeling sad and hopeless. Observe tearful, minimal eye contact. Denies suicidal ideation when asked directly using the screening tool. Social work consult placed. Physician notified for evaluation. You capture the severity, you document the required screening, and you show the referral.
So it's all about shifting the language from interpretation confused, depressed, to fact asking what day it is, tearful pulling at lines.
And when you coach it that way with these specific scripts, it reduces defensiveness. The message is supportive. Here's the exact better way to say that.
And that's how you get behavior change that actually sticks. It's about these weekly focus cycles, visible wins, and total clarity on the 5 phrases that create 80% of your unit's risk.
And you do it in a positive coaching environment.
Now, we've focused a lot on protecting the bedside nurse, but the CNO, the Don, the manager, they're all exposed too. Let's talk about the uncomfortable truth of leader exposure when these documentation failures are systemic.
The leader's liability shifts from being about clinical care to being about supervisory negligence.
So you're exposed if you can't prove you set clear expectations.
Exactly. If you can't prove you provided the right training and followed up on deficiencies, if every nurse on your unit is using WNL and it leads to a lawsuit, the plaintiff's attorney is going to argue that the facility failed to educate and monitor its staff, and that falls on the leader.
So as a leader, your own documentation becomes about proving you did the coaching.
It is your professional protection. If a nurse consistently uses an unsafe phrase, the manager needs a defensible note somewhere that says, on this date, this RN was coached on avoiding subjective phrases and was trained on the new standard. They verbalized understanding.
You're documenting your intervention to stop the systemic risk.
Yes. Because if you can't prove you trained them, the legal system will simply assume you didn't. This is why coaching logs and training sign-offs are absolutely essential for a leader's own protection.
And we have to talk about the cardinal sin of documentation that can undermine even the best care. The time factor.
Time is everything. It is the unyielding axis of a legal defense. If you can't prove when something happened, your defense against a claim of delay of care or failure to escalate is just gone. A 2-hour gap in charting on an acute patient can imply they were completely unassessed for that whole time.
So phrases like late entry untimed or using approximately without any context.
Those are non-starters. They immediately introduce doubt into the timeline, which is the first thing a lawyer will attack. A late entry needs absolute specificity about why it was late.
So if you were in a code,
You document that. Late entry at 21.0 for events from approximately 19.0, 19.30. Real-time entry delayed due to active resuscitation of patient in room 4. That detail is crucial. It gives the necessary defensible context.
and if the time of an incident is unknown,
You have to bracket it. You state the time of discovery and the last known time the patient was assessed as stable. For example, patient found on floor at 14.30. Last documented check at 13.0 showed patient in bed. Timeline of potential incident, 13.00 to 14.30. You reconstruct the timeline with objective facts.
So as we wrap up this deep dive, it feels like we need to reframe what documentation really is. For every leader listening, it's not clerical work.
No, it is the most critical professional communication you will ever make. Strong documentation tells the patient's entire story. The communication, the assessment, the advocacy, when the nurse is no longer there to defend their actions.
And that record is often read years later in front of a jury.
Where every single word is dissected for ambiguity and fault. It just has to be objective, factual, and complete. When you chart well, you're protecting that clinical excellence.
So let's review those golden rules from the guide one last time. These are the 5 non-negotiables for every note.
First, use objective, factual language. Drop the subjective interpretations.
Second, quote the patient directly whenever you can.
Third, show what you did, observed, and taught, and always use teachback to verify that understanding.
Fourth, do not make judgments. No non-compliant or uncooperative.
And fifth, and this is so important, do not admit fault or liability in the official chart. No error, mistake, forgot. Document only the objective facts and your clinical response.
The motivation for leaders is really simple then. Safer documentation builds safer teams. It reduces liability, it protects licenses, and most importantly, it ensures the amazing clinical care your nurses are providing is accurately and defensively recorded.
That's the goal.
Taking charge of documentation risk is really the ultimate definition of proactive nursing leadership. You now have the principles, you have specific scripts to start making visible, measurable changes today. It doesn't have to be this overwhelming thing.
No, just focused. We really encourage you to stop seeing documentation as a compliance task and start seeing it as a primary leadership lever for change. Pick one concept, just one. Maybe it's eliminating tolerated well from your unit's vocabulary.
Or making sure every refusal note documents the consequences.
Exactly. Apply it immediately this week and just see the immediate clarity and defensibility that it provides to your team.
And if you are looking for structured resources to really operationalize this across your unit, seek out high-quality training designed for nurse leaders that gives you these ready-made scripts and implementation plans. Give your managers the tools to coach and give your staff the specific language they need to succeed.
Find those resources that help you build a culture of clarity and support. That's how you transform these documentation time bombs into protective shields.
So here's the final thought for you to take back to your unit. What small, unsafe phrase is your team still using that you will eliminate first thing tomorrow morning?